Good evening, everybody, and welcome to our collaborative presentation of Talk Saves Lives in a virtual Narcan training. Talk Saves Lives was created by the American Foundation for Suicide Prevention. And the naloxone training is an adapted training from DMIS and CRAC. Typically, both of these programs are brought to you in person, but we are delivering this training virtually due to social distance recommendations. The scope of tonight's training, neither presenter is either a clinician or a medical provider. So if you have questions that are beyond the scope of this training, please make sure you contact your healthcare provider. I want to remind everybody the importance of self-care. If at any time you need a break, please take one. If you would like to speak to us later or after the training, we will be available for that. Just a reminder, we are going to be recording this training, and if you have any comments or questions on a personal level, we will make sure to address those after the recording has ended. We have a two-part training tonight. The first part is the Narcan training, and then we will take a very quick break, and then we will switch over to the Talk Saves Lives presentation. If any of the people watching this would like a box of Narcan, please indicate that in the chat box or contact me directly, and I will make sure that you get that. You'll be able to pick it up here at Ledgelight. I'd like to introduce myself and my co-host this evening. I'm Carolyn Wilson from Ledgelight Health District. I am the coordinator for the Groton Alliance for Substance Abuse Prevention. I want to thank you all for attending this event. My co-host tonight is Traci Boiselle. I will hand things over to her to get started.
Thanks, Carolyn. Good evening, everyone. As Carolyn said, my name is Traci Boiselle. I am a volunteer with the Connecticut chapter of the American Foundation for Suicide Prevention. Our organization is a nationwide organization having at least one chapter in all 50 states that in existence since 1980 and is now the largest private funder of prevention research. But we offer all sorts of programs like the one today, advocacy at government levels, as well as to provide support for those touched by suicide. I became involved in 2012 when I took part in my first Out of the Darkness walk. And I've been a volunteer member of the board now for 2 years. And I'm also the walk chair for the Niantic Out of the Darkness community walk. So I'm very excited to be here and present Talk Saves Lives for you guys.
Great, thank you so much. So glad that we're here doing this together. And I hope to do this again. All right, so let's start with our Narcan training. Give me 1 second here. I will pull up our presentation. Okay. So tonight we're going to be talking about Narcan, which is the brand name, if you will, of the medication known as naloxone, which is an opioid overdose reversal agent. As we get started here, I just want to tell you that I did not create this presentation, and I want to make sure I acknowledge Susan Buffard from DMIS and Angela Duhame from CRAC. All right, so when we talk about opioids, it's a class of medications and substances. So in that family, we have opium, heroin, morphine, pain medications, methadone, Suboxone, and synthetics. So there's a large class of things that we're talking about when we refer to opioids. This is a chart that shows the trends in lifetime use of illicit drugs among high school students in southeastern Connecticut. And as you can see, Illicit drug use is pretty low among high school students, which is something that's fairly true across the region. Less than 10% almost appears to be more like 5% or even less. Very low amount for high schoolers. If we look at prescription drugs in particular, we can also see the rates for southeastern Connecticut, and these numbers are only going up to about 2017 right now. If you have an interest in more recent data, I can get it for you, but this presentation is goes up to about 2017. So you can see the trends here over time, and they are on the decline. Couple things you need to know about opioid misuse, prescription opioid misuse. So a couple of the reasons why this has become such a huge problem. Overprescribing of pain relievers has contributed to a problem. Unused meds kept, especially opioids, so leftover pain medicine that's not secured. Sharing or diverting of prescription medications. So more than half of misused prescription opioids come from family or friends. So we have a couple of programs in all of our communities that address this issue. We tell people to, secure their medicine and dispose of it properly when they're finished with it, and to not give it away to other people. Because medicine comes from a doctor, sometimes people think it's safe just for that reason alone, and that it can't cause problems. Over time, I think many people realize that that's just not true, especially with a lot of different education in this area as this has become more of a problem. Prescription opioids are very closely linked to heroin use. So sometimes when the addiction becomes problematic and expensive, we hear oftentimes anecdotally that people will switch over to a cheaper or more available product, which sometimes is heroin. If we're looking at accidental overdose deaths, we can see the trend over time here. So the most recent data comes from 2019, and you can see there was a little bit of a spike after a tiny decrease in 2018. So it was on the up and up and up, and then it dropped a little bit and it went back up again. So that's where we are right now. This data only goes up to 2017, but this is an interesting snapshot of the problem. So if this is looking at Eastern Connecticut, we look at the type of people who've overdosed and died. An overwhelming majority are white and non-Hispanic, males, adult age 20 to 65, and middle age really 42 and a half years old. So this is a snapshot of who this is happening to, but as you can imagine, across the spectrum, there's really a little bit of everybody. If we take a look, I did update this slide. The last one only went up to 2017. But if we look at the most recent deaths put out by the medical examiner, you can see that polysubstance use is a huge issue. So oftentimes when people are using substances, they may be using more than one thing. So we know that contributes to a lot of these deaths. 94% of the deaths involved any opioid. So one of those things in that class that we talked about was found in the system of these people who have died. 82% had fentanyl in their system. Fentanyl, you're hearing more and more about it because it is the very strong synthetic opioid that's finding its way into the supply of heroin and into some of the illegal drugs. So the problem is sometimes it's sneaking its way into other things. 32 of the deaths, 32%, involved heroin, just heroin. 39% involved cocaine, which I think is a little bit surprising to some people. However, the problem is sometimes you're seeing the fentanyl in the cocaine, and that's happening. So sometimes when you're buying drugs off the street, you really just don't know what you're getting. Or sometimes you could just be using multiple things and it contributes to the overdose. And then of course, 45% included a stimulant. And we've seen a little bit of MDMA, which is ecstasy, and a little bit of methamphetamine as well. So those things are not as common in our area, but they're there a little bit. All right, when we look at risk, who is at risk for this? You could say almost anybody. We'll start with children and adolescents who access unsecured medications. So we talked about, things that are available, not locked up, not disposed of. Sometimes teenagers, when they're experimenting or partying, you sometimes hear about these things called farm parties where people are using pharmaceuticals. They don't really know what they're taking. They're just trying to have a good time. Sometimes that happens. Sometimes they do know what they're taking. Seniors who are prescribed multiple medications, who may not know what they've already taken or not know about certain drug interactions, that can also be a risk. People with chronic pain and on long-term opioids. Individuals with a history of substance use. And young adults between the ages of 18 and 25. You'll notice on some of the previous slides, it was showing very low rates for just teenagers. Once you graduate 18, we see those numbers go up in that 18 to 25 category. So really a wide range of people are at risk. So in any Narcan naloxone training, we want to talk about all these different factors. We want to know about the risk factors for overdose, identifying what might be an opioid overdose if you know somebody or you encounter somebody. We want to talk about Narcan as a substance, as a drug, the importance of calling 911, the importance of resuscitative efforts, and the recovery position. Those are things that we want to talk about. All right, when we talk about overdose risk factors, we want to talk about decreased tolerance. So sometimes we see that after somebody has been in recovery for a while or has been incarcerated. Any long period of not using, your tolerance goes down. Using alone, so if you're using an opiate and you're not with somebody else, if you overdose, there's nobody to call 911 or to give you Narcan. Mixing of substances, the quality and the strength of what you're getting. If you have multiple health issues or comorbidities, if you've ever had a previous overdose, the manner in which you take the drug. So if you inject it or smeared it or smoke it, that can play a part in it as well. And your age. So the older you are and the longer history of drug use, the more at risk you are for a fatal overdose. How do you identify an opioid overdose? An unresponsive or minimally responsive person, so you try to rouse them and you can't. Blue or gray face, especially the fingernails or the lips. This can indicate a lack of oxygen, that they may not be breathing. Shallow breathing, less than 10 breaths per minute or not breathing at all. Pinpoint pupils. Loud or uneven snoring or gurgling noises may indicate that they're having a hard time breathing. If you know that they're an opioid user, if you see track marks or syringes or pills in the area, pill bottles, or information from bystanders, maybe at a party or something, somebody can tell you what they may have done or what they may have taken. So it's really important to try to rouse them. So you want to call their name and shake them. If you don't know their name, it's hey you, it's hey you. You want to check for pain response. You can rub your hand hard up and down the person's sternum with your knuckles. It's not pleasant. Then you definitely want to call 911. You could even, argue if there's any concern that this might be what's happening, you really want to call 911. It's the number one thing you want to do. You want to get that person to help as fast as you can. And of course, if you have the Narcan, the naloxone, you want to administer it. But you always have to call 911. That's the biggest take-home message here, is you want to activate EMS because chances are they'll need another dose and they'll need to be monitored at the hospital. All right, naloxone, Narcan. It's a prescription medication. However, you can get it now from a pharmacist and through community programs like this one. It's a very safe medication. So it's very easy to use and safe. You don't have to worry about it. It only affects the person if they have opioids in their system. So if you encounter somebody who has had an overdose on something that's not an opioid, this will not work. It only works specifically with opioids. You can't get high from it, so there's no abuse potential. There's no street value. And if you are on opioids and you get Narcan or naloxone, it does cause some withdrawal. So the person could become confused or feel some unpleasantness. So it was very safe to use. You don't have to worry about allergies really, or taking the guesswork out of it. It's very safe. If you give it to somebody, if I were to give it to myself right now, I wouldn't do anything. It only works if there's an opioid in your system. Very important to know. So Narcan works really miraculously. It's very interesting. It works in the brain. So people can die from a lack of oxygen over a 1 to 3 hour period. So what Narcan does is it steals a spot on the opioid receptors in the brain. So breathing can resume while the Narcan lasts. Another reason why it's important to get medical help is because it will wear off and the person may overdose again. It works on any opioid. So it's so important to get it in people's system. So this is the science part here that talks about naloxone has a stronger affinity to the opioid receptors than the opioids, such as heroin or oxycodone. So it knocks the opioids off the receptors for a short time, 30 to 90 minutes. This allows the person to breathe again and reverse the overdose. All right, so now we're going to watch a quick video. Please bear with me 1 second. Check my sound here. Just have to find my sound setting here. All right, let's see here. Hold on 1 second here.
Teach you how to identify an opioid overdose, how to intervene, and how to use the various formulations of naloxone, such as Narcan, to reverse an opioid overdose. First, what do we mean by the term opioids? And how are opiates different than opioids? Both of these terms refer to the same basic category of drugs. The The only difference is that opiates are naturally occurring from the poppy plant, and opioids are synthetically created in a laboratory. The term opioids will be used to cover both. Most people know that heroin is an illegal, dangerous, and highly addictive opioid. What many people aren't aware of are the dangers associated with prescription opioids or painkillers such as Oxycontin, Vicodin, and Percocet. These opioids can also be dangerous and can lead to abuse, dependence, addiction, overdose, and death. What happens when a person overdoses on opioids? The opioids bind to specific receptor sites in the brain and slow down breathing. As breathing diminishes, vital organs like the brain and heart don't get enough oxygen, and eventually the person will die. But this process often takes 1 to 3 hours, which means there is time to intervene. The medication for an opioid overdose is naloxone. The most common brand is Narcan. Naloxone blocks the effects of opioids by stealing the spot of the opioid at the brain receptor site. When the opioid is kicked out of the receptors, the person's breathing resumes while the naloxone lasts. However, naloxone is a short-acting medication and will last somewhere between 30 and 90 minutes, enough time for EMS to arrive and transport the person to a hospital for further medical care. When the naloxone wears off, the person could experience a re-overdose because the opioid is still circulating in their system and could reattach to the receptor sites and again slow down breathing. This is why it's important for the person to go to the hospital for monitoring, even after they've been revived. How do you identify an opioid overdose? First, the person may be unconscious, unresponsive, or minimally responsive. Due to the lack of oxygen, they will look blue or, depending on their coloring, gray or ashen, especially apparent around the lips and fingernails. Their breathing will be labored, less than 10 breaths a minute, or no breathing at all. They will have pinpoint pupils, and sometimes they will make an odd snoring or gurgling sound. Often there is other evidence available. The person could be a known user, there could be pills or syringes laying around, or bystanders who witnessed what happened. The first step is to try and rouse the person by calling their name and shaking them. If you can get them up, walking around and talking, then the naloxone may not be necessary. Also, try using the sternum rub by making a fist and rubbing it hard up and down the person's sternum or breastbone. This causes pain, and generally the person will respond if they can. If they don't respond, call 911 for a medical emergency. When you call 911, provide as much information as you can and describe the person's breathing status. For example, they aren't breathing, or they aren't breathing much. Describe exactly where the person is located, such as they are in the living room. You want to provide as many details as possible so the person can be quickly found by emergency personnel. If you are alone with the victim, it is recommended that you provide some rescue breaths even before you administer the naloxone. Remember, it's the lack of oxygen that causes death. Rescue breathing is CPR without the chest compressions. Make sure the person is on their back on the floor. Open the airway by lifting the chin and tilting the head back. Make sure there is nothing in their throat that would block the airway. Begin by pinching their nose so the air you breathe in does not escape. Give 2 normal-sized breaths and then 1 breath every 5 seconds. After you give a few rounds of breathing, then you can administer the naloxone. Once the naloxone is given, continue with the rescue breaths until the person either revives or EMS arrives to take over. If there is more than one person, one can provide rescue breaths while the other administers the naloxone. Currently, there are 4 formulations of naloxone used in the community. 2 are intramuscular injections, and 2 are intranasal sprays. The first intramuscular injection is the traditional syringe and medication. For intramuscular injection using a syringe, pop off the orange top of the vial, remove the syringe from its packaging, and insert the syringe into the vial. Flip the vial upside down and remove the entire amount of Narcan, 1 cc, by pulling down on the plunger. Remove any air bubbles from the syringe by carefully pushing the plunger in. Insert the syringe into the upper arm or thigh muscle and push the plunger in. The second form of intramuscular injection is the auto-injector. Currently, the only brand of auto-injector is FZO. This product is similar to an EpiPen, and it talks you through the process. Each kit comes with 2 doses and a trainer device. All you have to remember with this formulation is to pull it apart and listen.
This trainer contains no needle or drug.
This injection will go through most clothing.
4, 3, 2, 1. Injection complete.
The first intranasal formulation is an atomizer, which converts the liquid medication to a mist similar to a nasal spray. The atomizer assembly has 3 components and requires assembly. The atomizer comes separately packaged, and the remaining 2 components are inside the box: the medication in liquid form and the plastic housing into which it is inserted. First, remove all the plastic ends. Next, screw the medication into the bottom of the plastic housing. It's important to stop when you feel resistance, otherwise the liquid medication will start leaking out the other end if you go too far. Note that this device contains 2 milliliters of naloxone, 1 for each nostril. Finally, screw on the atomizer as straight as you can. Insert the device into one nostril and squeeze in half the amount, then do the same in the other nostril. Finally, the newest intranasal formulation is a device that requires no measurement or assembly. This is the Narcan nasal spray. There is a very small volume of liquid in this formulation, so just select one nostril and squirt the entire amount by holding the device with your second and third fingers around the nosepiece and your thumb on the plunger below. Insert into the nostril just until the tops of your fingers touch the bottom of the person's nose. Then push up with your thumb. It is recommended to have your other hand supporting the person's neck and tilting their head back to ensure that none of the medication rolls out. Cost and dosage varies with these different formulations. Most commercial insurance, as well as Connecticut Medicaid and Medicare, will cover at least some of them. Grants or coupons might also be available on the websites of different pharmaceutical companies. Naloxone will expire in about 18 months, and it should be stored in moderate temperatures, not in the refrigerator and not in direct sunlight. What can you expect after you administer the naloxone? It may take a minute or 2 to work. In the meantime, you need to continue with the rescue breathing. If the person does not respond within about 2 or 3 minutes, you should give a second dose. When people are revived, they may be confused, upset, or even agitated. Actual combativeness is reported only about 1% of the time. Explain to the person that they have, in fact, been brought back from an overdose. If the person is dependent on opioids, they will be experiencing withdrawal symptoms, so prevent them from using again to relieve these symptoms. Ideally, the person will agree to go to the hospital, where they are typically monitored until they are deemed to be medically stable. People generally don't realize that they are overdosing. That's why it's so important to get naloxone into the hands of family members and friends. Communities across the country are becoming more involved in activities designed to reduce opioid abuse and overdose. Naloxone is an invaluable, life-saving resource in these efforts.
Okay, that's the video. Let me just pull up the last part of our screen share. All right, here we are again. So, great video, really outlines the importance of calling 911 and all the steps that need to happen. So when you call 911, it's very important to provide as much information as possible about the person's breathing. Describe exactly where the person is located. The more information you can give them, the better, because every moment counts. 911 may give you instructions for how you can help the person. It could be rescue breathing. And you want to stay connected to 911 if you can. You can place them on speakerphone in case you need to give rescue breaths. This shows what a rescue position looks like. So this is how you may want to position the person as they're coming about. People will usually be revived within 2 to 3 minutes. They probably won't really know what happened, and you may need to reassure them. They may feel really confused, just like the video said. Most people are not violent. They can be aggressive, but that's not reported often, probably about 1% of the time. But they're becoming very uncomfortable, so just keep that in mind if you should have to ever do this. They're not really going to know what's going on. They're not going to feel great. Like the video said, if the person doesn't respond to the naloxone within 2 to 3 minutes, you want to give another dose. And the person could re-overdose depending on how much they used. So you definitely want to get them medical care. They really need to be seen and monitored. You want to store Narcan in moderate temperatures, out of direct sunlight, not in a refrigerator, and it should last for about 18 months. So that wraps up our Narcan portion of tonight. If you have any questions, you can contact me. And of course, after you've seen this, if you want to get a dose of Narcan, you can do that. Just contact me and we'll get it to you. Okay, so that was part 1 of tonight's training. Right now, I think we're going to take a couple of minutes just to switch gears, and then we'll come back and we will start our Talk Saves Lives presentation. Okay, we're back. So I'm going to pull up our presentation. All right, I'm going to hand things over to Traci to start today's presentation.
Will you need to change slides for me?
Yes.
Okay. All right, everyone. Thanks again for joining us. I'm going to take you through our program, Talk Saves Lives. This is a community-based program. Just provides a lot of great information so that you can be an active member of the fight to stop suicide in our communities. So if we could head over to slide 1. These are our self-care resources. Like Carolyn mentioned in the beginning, self-care is critical. We are lucky in the state of Connecticut because when you dial 211 and press option 1, you are directly connected to mental health care providers and resources in the state of Connecticut. This is unique to very few states, and Connecticut is luckily one of them. Of course, there's the National Suicide Prevention Lifeline. I do encourage you to, by the way, to put these numbers into your contacts in your phone, should you ever need them, or just in case you come across a friend or loved one. The Suicide Prevention Lifeline is available 24/7, as well as the crisis text line. Especially younger people now, we find are using the text line a lot more. The Trevor Project number is there as well for our LGBTQ community. Should they need support, that's a little bit more specific to their community. Again, maybe take a snapshot of the screen, put these numbers in your phone, save them in your contacts. You just never know when you could be the person that makes the difference.
I'm Christine Montier,
All right, so this is
Medical Officer at the American Foundation for Suicide Prevention. Thank you for taking the time to attend this program that you're about to participate in. I wanted to make a few comments since we are in the midst of this public health crisis related to the coronavirus. Factors associated with COVID-19, such as anxiety and social isolation, fears about the virus itself, and the potential for economic strain on families. Everyone is making adjustments, and every single situation is important for us to consider as it relates to the impact on our mental health now that we're in the middle of this unusual time. So I wanted to just explain a few things about what you're about to hear about suicide risk and prevention so that there is not an unintended combining of or linking of coronavirus with suicide risk. In fact, based on research available currently, it is not a foregone conclusion that COVID-19 and the crisis that we're in will have an impact on suicide on a population level. While factors associated with COVID-19 can, in fact, create risk, it is more important than ever that we remember that suicide is preventable. And so it's a time when we can pay attention to all the proactive measures that we can take to protect our mental health. And for those who have specific vulnerabilities, such as depression, PTSD, addiction, or really any mental health condition, or other vulnerabilities that have been in their history, that could include a family history of suicide or a past attempt. For all of those, it's very important to be thinking about protecting our mental health, engaging in supportive, healthy relationships in your life, and engaging in treatment. While we are in the midst of an unprecedented public health crisis, we also have an extraordinary opportunity to come together and concentrate on mental health. There has never been another infectious disease epidemic ever in history when mental health has been part of that national dialogue, and it is at this time. So it's a time when we can clearly focus on our mental health like never before, and we have certain other advantages. For example, the use of telehealth has suddenly skyrocketed into an available place because of the coronavirus. The federal government has passed legislation so that people can see a doctor if they think they have symptoms of coronavirus, but it also means that we can see a doctor or a therapist if we're concerned that our mental health is deteriorating. So I would encourage everyone to think about that and check your insurance to see if you have access to telemedicine or teletherapy. We must use these tools to our advantage and remain vigilant to protect our own mental health and to support our loved ones. I encourage everyone to engage in open and honest dialogue with your friends and with your loved ones. Check in with each other, ask how you're doing, be willing to share yourself. It is a more stressful time, so everybody's stress level is just a little bit elevated. So we need to actually show even more compassion and kindness. We need to practice self-care in spades. Now is not the time to forget about the basics of protecting your sleep, your nutrition, exercise, and that really means also drinking a lot more water than usual and drinking less alcohol than usual. And think about all of the other self-care activities that you know ground you. One last word of encouragement. Consider the people around you who others might not be thinking of reaching out to. Think especially about the elderly people in your life. Consider reaching out to them and offer to lend them a listening ear or a supportive hand in terms of errands or walking their dog, or really just expressing support. Even though this is a time of social distancing, to me, that really means physical distancing and not a time to socially disconnect. And so let's use technology in order to connect with loved ones and to be thinking about those who might be vulnerable during this time. Thank you again so much for participating in this program. Let's come together as families and communities and support one another during this time. Thank you.
Sorry, Traci, I jumped the gun a little bit on that one and you didn't get to introduce it. I'm sorry.
No, that's okay. There's nobody that can say any of this better than Christine Moutier. She is a powerhouse. I was lucky enough to meet her on more than one occasion. If you ever get a chance to watch anything else that she speaks about, definitely take that time. She's amazing. So no worries.
Okay.
All right.
All right, let me just get to our next slide here.
Yep. All right, so this slide speaks for itself. Suicide is a complex health issue. Just like any other physical health issue, this is definitely something that is and should be of the utmost concern. It's an epidemic as well. It's a health issue. So despite the complexity of suicide, there's usually never just one cause. It can be prevented, just like other health conditions. We can learn the warning signs and how we can help someone, just like we would with heart disease or the risk of heart attack. If we learn to recognize the signs, we can help to mitigate in the situation where somebody may be at risk for suicide. So as with other other health issues, prevention can start early. You can start far ahead of the problem through these types of things here, understanding. We're going to go through the scope of the problem in our communities as well as nationally. We're going to go through some of the research findings of AFSP and the researchers that they funded, how we can take part in prevention, and what you as individuals can do for your loved ones or even for yourself, which is so important as well. And how we talk about suicide really, really matters. We want to create a culture where there's no stigma or less stigma than there is right now. It's important to model appropriate language so that we can mitigate these stigmas and around suicide as well as mental health in general. So we want to try to, let's go through these here, do's and don'ts here. We want to try to avoid saying committed suicide. This implies some sort of negative connotation. We don't, for example, say someone committed a heart attack or committed some other organ failure that caused their death. So committed suicide is something that we do want to avoid. We want to try to avoid words like failed or successful attempt, because that indicates possible judgment, and we know that judgment isn't really at all a factor in the situation of a suicide. Instead, we want to use terms like, in place of committed suicide, died by suicide or ended their lives, killed themselves. And for a failed or successful attempt, we just want to say either a suicide attempt or a death by suicide. So the scope of the problem, I'm going to hand you over to Carolyn. She's going to take you through some of the information that AFSP has provided us.
Right, thank you, Traci. All right, so suicide is a significant issue that affects individuals, families, and communities worldwide. So let's start with some statistics that demonstrate the scope of the problem. So over 800,000 people die by suicide each year, according to the World Health Organization. While this is the most accurate data available, we estimate the numbers might be higher since suicide is underreported in many countries. We know that somebody dies by suicide every 40 seconds. In the US, suicide is the 10th leading cause of death. In 2018, nearly 50,000 people died by suicide. Suicide takes more lives than homicide, war, and natural disasters combined. These high numbers are one of the many reasons that it is important to talk about suicide like any other cause of death. The more we talk, the less stigmatized the idea is, and that we all face struggles and need support. For every death by suicide, it's estimated that 25 others attempt. That's about 1 million Americans each year who survive a suicide attempt. Suicide impacts individuals and communities. When you think about any loss, it impacts many people in the community. Suicide is no different. The loss affects family, friends, coworkers, and neighbors. It's estimated that majority of Americans will experience a suicide loss over the course of their lifetime. So if we look at this slide, we can see some of the updated statistics here in Connecticut. So in Connecticut, suicide is the 11th leading cause of death in Connecticut. But if we look at some of these age groups, we can see that it leads. So it's the second leading cause of death for those who are 10 to 34. It's fourth for people ages 35 to 54, seventh for 55 to 64, and 17th for those over 65. We know on average one person died by suicide every 21 hours in the state of Connecticut. More than 3 times as many people died by suicide in Connecticut in 2018 than alcohol-related motor accidents. The total deaths to suicide reflected a total of 6,798 years of potential life lost before the age of 65. The costs of suicide in Connecticut, $410 million combined lifetime medical and work loss cost in 2010, or an average of $1,163,740 per suicide death. And down here you can see how Connecticut compares nationally. We are the 45th in the country for states. So because I'm a coalition coordinator, I do a lot with youth data. And so it's important to know that the Department of Public Health collects data, the Youth Risk Behavior Survey, every 2 years. This data is from DPH. So if we take a look at mental health and other attitudes and feelings. 10 students out of a classroom of 30 said that their mental health was not good at least 7 days in the past month. So you have a third of the kids saying that their mental health recently hasn't been great. 4 or 5 students of those 30 purposefully hurt themselves in the past year, such as cutting or burning. 9 out of 30 felt sad or hopeless for a 2-week period sometime in the last year. Only 2 of these 9 students said they usually got help when they needed for feeling sad or hopeless. 4 students seriously considered attempting suicide in the past year. 2 students actually attempted suicide in the past year. And once again, these statistics are out of a classroom of 30 students. And this is from the 2019 Connecticut School Health Survey. All right, we're going to switch gears into a different segment of this training. And I'm going to pass things over to Traci.
All right, so as I said earlier, AFSP, or the American Foundation for Suicide Prevention, is the largest private funder of suicide prevention research in our nation, which is fantastic. And all of this comes from donations and fundraising for the organization. So just to give you some information, over the past, it's only been in the past several decades that scientists have even been studying suicide, shedding light on critical areas surrounding it. They've been researching what drives up risk and what amounts to effective suicide prevention. Why do people take their own lives? There's no single cause of suicide. Most situations is several stressors and health issues combining and converging to create a state of despair and hopelessness. The majority of people who die by suicide have mental health condition contributing to their death. They may or may not be recognizing their own situation, or their loved ones may or may not be recognizing it, and they also may not be diagnosed or treated. This is 1 in 4 people will experience a mental health condition, and most do not go on to die by suicide. Mental health conditions are not the full story. A vast majority of people, as the slide indicates, do not go on to die by suicide who struggle with mental health issues. Part of the amazing research that's been going on and some of the things that have been discovered is that there's actually physical differences in the brains of those that die by suicide. Based on, compared to other causes in both structure and function, there are differences. The brains of people that die by suicide differ in structure and function in areas related to stress response and impulse control. So these are legitimately documented physical differences in the brain. Most people who die by suicide are ambivalent about taking their lives. Part of them wants to live, and part of them wants to die. Research shows prevention involves engaging the part of the person that wants to stay alive and creating a distance from the part of them that wants to die. Helping a person to connect with reasons for living while decreasing visibility and presence of the things around them that may facilitate their desire to die are critical. So the perspective of a suicidal person, by this point, we're talking that the crisis point has been reached. They're desperate to escape the pain and their thinking becomes limited. Research about the perspective shows that the crisis point, sorry, I just lost my train of thought. If you take a moment for yourselves and think of the most physically painful experience of your life, would you have been able to give clear directions to your house at that time? Probably not. So the pain makes ordinary things nearly impossible. So their judgment is completely limited. They're in extreme, unbearable pain, whether it's emotional, physical, or sometimes a combination of both in situations of people with chronic pain issues or chronic diseases. Who is at risk? the characteristics or conditions that increase the chance of a person to take their life, it's important to know this big picture. Just like heart disease or high cholesterol, some are at higher risk than others. There's 3 categories, and generally what happens is when these categories converge is when we have a situation. So risk factors include health, historical, and environmental situations. Biological and psychological issues, mental health conditions are the most significant as far as health. Depression is the most common mental health condition and most associated with suicide. Bipolar, also at high risk, but less common than depression in mental health conditions. Detecting mental health conditions is critical. Many people don't even realize that they're in distress or that their mental health has actually become a health problem. You being able to provide information if you're concerned on how to access mental health care or a crisis number can be a solid step to helping people in this situation. So here's just an outline of some of the mental health conditions that can contribute. Anxiety disorders, we mentioned depression and bipolar disorder, eating disorders, personality disorders, psychosis, PTSD, and substance abuse disorders as well. Other health-related factors I briefly touched upon, serious or chronic health conditions, chronic pain, serious head injuries can cause a risk factor. And historical factors, such as a family history of mental illness or past trauma like sexual abuse or combat stress can cause an increased risk. A family history of child abuse, previous suicide attempts by the individual, or someone who's actually experienced a loss by suicide can be at a higher risk. Environmental factors. So these include access to lethal means, exposure or contagion, this being in the situation where, say, for example, a young person is exposed to a suicide at their school. Prolonged stress is definitely a factor, as well as a stressful life event. So generally, when we're exposed to another person's suicide, we tend to feel that there's just one cause, when there can actually be a combination of many. Prolonged stress in young people, especially things like bullying, an older person, maybe they have legal issues or they lose their job, something like that that can cause a lot of stress. What others see is, like I said, one thing. Perhaps the person just got divorced or they lost their job, and we think the suicide is caused by that one life event, when in fact all of these other situations are probably at play. They may have a genetic risk, they suffer from depression themselves, now they have prolonged stress at work, and they start to drink more than usual. So it almost becomes like it is the perfect storm of situations that converge upon this person. So the importance of research is to help us to understand what can cause a suicide and what can also help to prevent and to alleviate the signs and symptoms of mental health. Research must continue. They're looking for biomarkers and blood samples that could help to identify people at risk just by their blood and their genetic makeup. Help us identify new treatments. As we know, many treatments do not work for everybody, so there's a constant need to continue to find new psychotherapies, new medications. Most effective are programs and interventions to reduce suicide rates like this and to reduce the risk of those with mental health issues. All right, prevention.
Okay. All right, so I'm going to start talking about prevention. All right, just like there are risk factors that increase a person's risk for suicide, there are also protective factors that lower a person's risk. If you are proactive about mental health and make an effort to get healthier, you protect yourself. More on this in a moment. Feeling connected to family and community support can protect against suicide. When someone is struggling with depression, anxiety, psychosis, or substance abuse, these protective factors that may normally be strong can erode and temporarily weaken. When that happens, having friends and family to remind us of our strengths can be a tremendous protective factor. Problem-solving skills also help. They can get really tough. Life can get really tough. But being able to see a way through problems can be a protective factor. Cultural and religious beliefs that encourage connecting and help seeking and discourage suicidal behavior or create a strong sense of purpose can also be a protective factor. Because mental health care is so important for preventing suicide, we're going to focus on this topic for the next few minutes. Getting effective treatment for mental health conditions like depression or anxiety can prevent suicide. We need a culture where everyone knows to be smart about mental health. One way to encourage individuals to seek help for their mental health conditions is to treat mental health like any other aspect of health. There are certain times when a person becomes ill and it's critical for them to seek a trained professional. We need a culture where everyone knows it's smart to take care of our mental health. Unfortunately, only 2 in 5 with a mental health condition will ever seek treatment. Critical to suicide prevention is getting people connected to mental health treatment. One of the biggest challenges in fighting suicide is getting people to address their mental health in the same way that they would for physical health. In fact, of those suffering from a mental health condition, less than half seek treatment. One way to encourage individuals to seek help for their mental health conditions is to treat mental health like any other aspect of our health. There are certain times when a person becomes ill or has a chronic health condition to manage, and it's critical to seek a trained professional. We need a culture where everyone knows it's smart to take care of our mental health. It's so important to be proactive about mental health. It's important to make it a priority, to go see a doctor or mental health professional, to get an evaluation, to discuss treatment options, and to find out what works best for the individual. The good news is that advocacy efforts are improving access to mental health services so that more people can get the treatment that they need. The law now requires insurance plans to cover mental health services on par with physical health services. If we need mental health services, and one out of 4 of us will at some point, we should get treated and get our health back on track faster. There are several ways you can take care of your mental health on your own. 1 is by getting plenty of exercise. 2 is by getting good sleep. 3 is by eating a healthy diet. And 4 is stress management. And also, it's really important for us to talk about support for loss survivors and those with lived experience. Prevention also includes supporting those touched by suicide. The loss of one person to suicide profoundly impacts many. It's important that survivors have the support they need, both to heal and to reduce their own risk of suicide. And since those with lived experience, those who have attempted suicide or experienced suicidal thinking, are at increased risk, we need to make sure that they have the support that they need to. The most important thing you can put between a suicidal person and their way of ending their life is time. Research shows that by temporarily reducing a suicidal person's access to lethal means, we give the suicidal individuals time for the intense suicidal risk to diminish, and time for someone to intervene with mental health supports and resources. In most cases, when a suicidal person doesn't have current access to the means that has been on their mind, they don't substitute with another method. Therefore, a clear way to prevent suicide is to limit access to lethal means. Some of the things that are available to help are carbon monoxide sensors in cars, blister packaging for medication, barriers on bridges, and secure firearms. All right, so for this next section, I will hand things back over to Traci.
Thank you. So what can we do as community members, family members, loved ones, or even for ourselves? We've provided you with a ton of information here, and I know that suicide and suicide prevention, mental health, it all may seem a little bit overwhelming, but we all have the capability to prevent suicide and to help someone with their mental health. The first thing to do is have a conversation. Just show that you care and ask that they share what they're experiencing and really listen. Learn the warning signs. So we talked earlier about the risk factors, but there's specific warning signs. The risk factors occur a little bit farther out as far as like the DNA and the situations, but the warning signs are closer to the actual possible attempt. And as Carolyn said, time is critical. So you want to reach out to this person and also help them to seek help. So the suicidal warning signs are here listed in front of you, and we do have resources that can be provided through our chapter. Just as a side note as well, we have wallet cards that you can carry, the Lifesaver's Guide, that you can put into your wallet with these warning signs clearly outlined just for your reference. And if you do want to get those, we can provide you with the contact information at the conclusion of the presentation. Many do talk about actually ending their lives. They either do it directly or indirectly. They may say it outright or they may joke about it. Always take it seriously. They may say things like they have no reason to live. They may say things like they feel trapped or that they're a burden, feeling overwhelmed, or they're in extreme pain. This is kind of outlined here. Exactly what we just said. People think that suicidal folks are not going to talk about their ending their lives, but some truly do. So listen, and it's not something to joke about. If you have an inkling of concern, express to the person that you are concerned. Changes in behavior are very, very prevalent, and these are the ones that you want to watch out for. Increased use of alcohol and drugs, issues with sleep. These are things that are uncommon, not just day-to-day changes. These are things that have drastically changed. They're acting recklessly, withdrawing from activities that they used to love. They're isolating themselves from family and friends, and they're looking for ways to kill themselves. They may, for example, searching the internet or looking up things along that nature. They may start giving away their possessions. Their mood is going to change. They're going to seem more depressed. These are things that are not common to their normal mood. So they may seem very depressed. They seem to just be apathetic and not really care one way or the other. They may show extreme rage, irritability, impulsivity, humiliation, and anxiety. But also it's important to remember that they may act out of characteristically happy. If they've actually decided on a way to end their life, they may actually feel a sense of relief, and a person who is not generally very, very outgoing and outwardly happy may show signs that are not common. Trust your gut. If in you is telling you that you need to reach out, that's the time that you need to reach out. One of our other programs is called Seize the Awkward, and it is awkward, but assume that you're the only person who's going to reach out. Take it with that notion. You might be the only person that reaches out. How can you reach out? You want to talk to them in person and in private, if you can. If you can't, these times make it a little more difficult to talk in person, but you could talk via technology, over the phone, through a video chat. Don't minimize their feelings. People with major depression, people who do not have major depression or anxiety really can't understand what the person is going through. Express concern and caring. Try not to minimize their feelings, and do not try to convince them their life is worth living. At this time, they're in a critical, very difficult state, and they're at a crisis point, and philosophical debate is really not going to be very helpful. You want to help them find professional help, and maybe even offer to go with them to see someone. If you're in a situation where you think they're in dire need, tell them that you're going to take them to the emergency room and go with them. Follow through. Help them make their environment safe for themselves. And again, the one we didn't mention there is avoid advice on how to fix things. You can't fix a heart attack when it's happening. So you're not going to be able to fix the person's crisis at this point. The best thing that you can do is to just help them get to the help that they need. If you feel like you're in immediate danger, however, in a situation, you want to remove yourself and call 911. However, if in any way you can stay with them, you want to stay with them. You want to help secure and remove the lethal means that we mentioned. If they have firearms in the house or if they have access to medication, stay with them, follow through, escort them to mental health services or to the emergency room if you think a situation is critical and happening soon. And again, here we have the 2 numbers, and as I said, if you save them into your contacts, that's really the best way to go. You might never need to use them, but just having them at a quick dial of the phone is really critical, either for yourself or for someone that you love. Again, the Lifeline and the Crisis Chat Line are available 24/7. And again, for emergencies, always call 911. So together, through trainings like this and just reaching out to those we love and talking and feeling comfortable sharing our own feelings and our own comments about mental health, we can create a culture that's smart about mental health and suicide prevention. And that's really what we need to do. We mentioned it more than once. A mental health condition is simply a health condition, and we need to look at them in exactly that way. One of the things that we do ask, or AFSP National does ask, if you could help us to improve the program by completing the feedback form. And again, you can take a quick snapshot here if you're willing to. Just visit afsp.org/TSL participant, and there's just a brief survey there. And AFSP is really, really good at following through and taking feedback very seriously. We can be found on all social media outlets, Facebook, Twitter, Instagram, and YouTube, AFSP National, as well as AFSP Connecticut. We are on, AFSP Connecticut has a Facebook, a Twitter, and an Instagram, so we can be reached on any of those platforms.
Wow. So, Traci, thank you so much for joining me tonight. You and I collaborated on 2 very heavy topics.
Yep.
And
topics that unfortunately go too closely hand in hand.
Yes. Some of you may or may not know now, the norm when anybody does a Narcan training is to also include suicide prevention training as well, and to not have those things be mutually exclusive. So in the future, as we offer more Narcan trainings or even more suicide prevention trainings, it'll be common to couple those together. So I just want to thank you so much, Traci, for joining me. I'm so glad that we got to collaborate on this together.
Thank you so much for having me.
Yeah, I mean, it's really so important. And I thank you for all of your work with the AFSP. It's truly amazing. Unfortunately, we know that when things, affect us personally, we become more and more passionate about them, of course.
Absolutely.
So,
I do encourage anybody who watches this video or has any need for support, please reach out to AFSP. You can visit afsp.org/Connecticut and find resources locally here in our communities that AFSP provides. As I mentioned briefly, we have different programs, one called Healing Conversations, which sends trained volunteers out to help those who are touched by suicide. There's just a lot of great programs, and our community walks, a lot of folks think that they're sad, somber events, but they're actually very hope-filled and very inspiring. And so check out the schedule. Hopefully this fall we'll be out walking in person. If not, we'll definitely have some virtual events coming up. And close by us here in Southeastern Connecticut, the Niantic Walk is due to happen October 17th. So hopefully we'll be able to get through that in person in some way, shape, or form.
Great. We'll be looking forward to that. Well, I think we'll end tonight's recorded presentation. And once again, if you have any questions about this, you can reach out to either me or Traci. And once again, if you would like to get Narcan, please contact me and I will get it to you as soon as I can. Thank you very much and have a good night.